Good evening, one and all joined for this panel discussion organized by IAME as a monthly event. I, Dr. M. Vijay Karthigeyan, National Treasurer of IAME, feel very much privileged to welcome the eminent panelists, the moderator, the office bearers of IAME, and all the faculty students who have joined for this panel discussion on the topic Sustaining the Family Adoption Program. What are the roles of faculty, students, and community stakeholders? So, with no further ado, I would like to invite Dr. S. Kribakaran sir, who is the founder and National General Secretary of IAME, as well as the Senior Assistant Professor in the Department of Community Medicine, Government of Mandura Medical College, to deliver the welcome address. Over to you, sir.
Hello, everyone. It gives me immense pleasure to welcome you all to our IAME's panel discussion on the topic that lies at the very heart of community-oriented medical education, that is FAP, sustaining the family adoption program, the role of students, faculties, and community stakeholders. And I'm honored to welcome all the senior faculties across the nation, being as distinguished panelists here, the big names from IAM, IAPSM, and they are from they have vast experience and diverse perspectives also. And I would like to extend my warm welcome to all the participants who have gathered here on this day. Best wishes to the IAME organizing team. Thank you so much. Over to
Thank
you,
you, sir.
Mohit.
So now it's time to invite the moderator for today's panel discussion. So a young and dynamic person, Dr. Mohit N. Makwana, who is currently the Assistant Professor, Department of Community Oncology from Gujarat Cancer and Research Institute, Ahmedabad. So he has completed his MBBS from the prestigious BJ Medical College, Ahmedabad, and also has completed his post-graduation in community medicine from Government Gujarat Medical College, Bhavnagar, and also he secured the first rank in his post-graduation. He has also completed his training in community mental health from NIMANS and has led 40 plus community outreach activities and cancer screening programs across Gujarat. And he also has guided more than 20 research projects, including mixed method and survival analysis, and also has more than 10 publications to his credit in high impact factor journals. And also he has coordinated 9 plus institutional academic exposure visits for the postgraduate students involving more than 120 students. And he has also delivered more than 25 invited talks and training programs for both undergraduate, postgraduate students, as well as health professionals. So he is a mix of experience in communication skills with leadership quality as well as field experience. And he is also very much known for his academic activities in various prestigious associations like IAPSM, and also is involved in community awareness drives as well as in digital engagement. So with this introduction, I would like to hand over the forum to Dr. Mohit. You can kindly take over.
Thank you so much, Dr. Vijay Karthikeyan, sir. Namaskar. Good evening, everyone. Myself, Dr. Mohit Makwana. I welcome you all for this panel discussion, Sustaining the Family Adoption Program, role of faculty, students, and community stakeholders. As we all know, that family adoption program is running all over India in all the medical colleges of India, and it is a very huge part of our community-related activity. And this program is very crucial that because this connects students with the community, and it helps them to learn health and social aspect as well. So today we will explore more aspect about this family adoption program and how we can sustain this program, because many of the time many institutes and faculties found it very difficult to sustain on a longer way, But today, I'm very excited to have a very experienced and eminent faculties from across India who are with us on this panel discussion. I would like to introduce one by one. First of all, Dr. Animesh Jain, sir. He is a professor at Department of Community Medicine, Kasturba Medical College, Mangalore, Mahe. He is a Fimer Fellow and faculty at PhD Fimer Institute at Coimbatore and MPhil at Manipal. He is also Deputy Coordinator at MEU KMC, Co-Coordinator at University Center of Education Research, Mahe. He holds multiple advanced qualifications like MD, Diploma in Bioethics and Medical Ethics, along with the MBA, and recently passed in 2025. Core member of Academic Council for Clinical Research, ISCR, served on the National Governing Council of IAPSM from 2023 to 2025. He has contributed and conveyed many IAPSM MBBS logbook. He was awarded Fellow IAPSM in last year, Distinguished Alumni Award in 2014, Best Innovative Teacher Practice in 2019, Dr. V.N. Mishra Oration in the present year. He's also academic editor for PLOS Global Health, Global Public Health, PRJ, and Frontier in Medicine. He has 100 plus publications, guided many PhD scholars, authored and edited many books in community medicine. I am very excited to have Dr. Animesh Jain sir in this discussion.
Thank you.
Next is Dr. Hemangini K. Shah, madam. She is associate professor in Department of Community Medicine, Goa Medical College, Goa. She is member secretary, Medical Education Committee of her institute. She is also Fimer Fellow and SCMA certified. She is course faculty for CBME in Community Medicine, MEU India. She is coordinator IAPSM eConnect Academia. She is also a faculty for national workshops on NCHPE, IAPSM Con, and other forums for multiple workshops. She also served as a chairperson, judge at IFA Con, IAPSM Con, Remisi Con, etc. She is lead coordinator for IAPSM's FAP position paper initiative, and she also received best paper awards at international medical education conferences like UCHPE and SDUA HER. And she has more than 24 publications in national and international journals. So I'm welcoming Dr. Hemangini, madam. Next is Dr. Sitharaman, sir. He is a professor of community medicine at Mahatma Gandhi Medical College and Research Institute, Puducherry. More than 20 years of experience in teaching, research, and academic leadership. He is a former head of department and MEU coordinator at KMCH Coimbatore and MGMC Puducherry. Also former faculty at SRM University Chennai and PhD Institute Coimbatore. He has done his MBBS from Sri Ramachandra Medical College Chennai and completed his MD Community Medicine from PhD Institute of Medical Science Coimbatore. He has more than 50 publications in national and international journals. He's very expert in spatial epidemiology, e-portfolios, community-based learning, childhood nutrition and health, professional education. He designed and implemented innovative learning modules, several copyrights for educational use. I am very excited to have Dr. Sitharaman sir, welcoming sir to the panel discussion. Next is Dr. Shruti MV. She is associate professor in Department of Community Medicine, Amla Institute of Medical Science, Thrissur, Kerala. She has 8 years of post PG experience in teaching. She done her MD Community Medicine from Amla Institute of Medical Science, Thrissur, and completed MBBS from MES Medical College, Perinthalmana. She is experienced across UG and PG teaching, field posting, and research guidance. She has published more than 15 research papers in national and international journals. Topic includes maternal and child health, NCD, lifestyle medicine, and adolescent health. Active involvement in community-based projects, including urban slum assessment and dengue control studies. Her focus area are community health research, NCD risk assessment, adolescent health, and public health education. Excited to have Dr. Shruti madam on the panel. Welcoming Dr. Shruti ma'am.
Thank you.
So let's begin our panel discussion now. So the first question to all the expert panelists regarding this discussion, that how was the family adoption program evolved under the CBME, and as per your experience, uh, what are the key outcomes that you have observed in the FAP? So kindly throw some light on this topic, like how the family adoption program evolved under CBME and what are the key outcomes that you have observed.
I would like Dr. Animesh to take a lead in starting the session.
Okay, thank you. So yeah, fine. I mean, somebody has to start. So let me thank you, Dr. Hemangini. See, what I would say is that, see, we all know, I think all of us know, including the audience will know, that family adoption program is taken and inspired by something known as village adoption program, which has been there in Sevagram. Okay, Mahatma Gandhi Memorial Institute of Medical, I mean MDIMS Sevagram. So there it was there, and it's still there. In fact, I've had the opportunity to visit the field and even see the family adoption, I mean, the village adoption program, as it is called there, there. Okay. So it's a very good program, well-intentioned program. Let me say that. However, having said that, I think when we got this directives initially from NMC, there was a lot of ambiguity and there was also kind of resistance. Obviously, because this was something which required a lot of thought process, say facilitating many of the challenges, including transportation, liaising, and things like that. So when it started off, it did have its own challenges. And if we look at it, how it has evolved, that's the question. So I think from 5 years back or so and to now, definitely it has got a little more acceptance, to be frank. There has been more acceptance. Yes, there are challenges, there are troubles. The teething trouble, some of them have been ironed out. There are still some more. But then, having said that, we know that it has been taken up, and some of the places there has been very positive response to it. So yes, that has been there. But we need to understand that, and I always keep saying, with no disrespect and no offense meant to anyone, I think what we need to do is we need to give a little more flexibility to this. So what has happened is this has, like, the program has evolved, and each place has also over a period of time realized how they could adapt and adopt it. So that's the thing which has happened. And there are now things, including IAPSM initiative last year, where there are success stories. There are things, paintings, there are stories, there are essays, there are, so that has also motivated people. So that, if you see, again, has happened. And there are some publications which have come out. There are people, including one of our famous fellows and my mentee, is working on coming out with something which will be able to assess. And I saw the chat, there is a question from one of the I think participants, one of the early questions. It's, I think Dr. Mohammed Kodke has asked that how to select teaching learning and how do we assess the in the field. So there are things which are coming up. So there are people working on it, and I think what we need to do is we need to think of how do we make it better and how do we adapt it. And that flexibility aspect should be there. But over a period of time, there has been a little more positive development, faculty and students. It has got into the curriculum. Initially, it was more of a, I mean, if I can use the word, it was more of a eyewash, or kind of, they were just doing it. I'm not saying all, but many of them were doing it just for the sake of doing it. But now it's taken up a little more. So that has also happened. So many of these things over a period of time, and we need to give some time for people to, like, but of course, as I said, there are certain challenges still, and it is difficult to go out of the field practice area and then keep changing it with every batch. Those things are still there. We need to look at it and how to manage. And again, each student being given 5 families or 3 families is not an easy job. And again, in some of the places, including the place that I am in, that is Dakshin Kannada district or Mangalore city, it's very difficult for us to find such families because the socio demographic pattern is very different. So when we have well off and people who are educated, and they already know what to do, and so but then we'll have to work out things. So we do, and we have been doing that, and we have also evolved quite a bit from where we started. So that's just for the starter. I'll leave it to the other people to talk, because if I talk everything, it will be difficult. I will come back in case I need to pitch in again. And thank you, Dr. Hemangini and Mohit, for asking me.
Thank you,
I
sir.
agree, Dr. Animesh. You have put in all, a brief of an overview kind of an FAP scenario. I too definitely feel that FAP has evolved over a period of time. When it came, it actually hit us. We didn't know what was going on, and everybody was scrambling here and there to try to put things together. Now, NMC itself realized it, I suppose, and instead of the five mandatory families, they became a little flexible and they said three minimum. Because for many states, they are too small to have so many families that could be there. So that was a good relief that came up, that three minimum. And ideally, of course, if you can put in your five, this as per the 2023 guidelines. So in India, if you look at the entire country, I feel we have a spectrum. On one side, we have the strugglers who are still trying to put things together. On the other side, we have somebody who's already implemented and are actually walking the talk. So they are established institutes who have a very strong community root culture, like, a similar kind of Sevagram kind of establishment. And there are most of the others are the ones in between who are able to do it, but having their restraint or their constraints, they are, coping up, but with a lot of stress and difficulty, I suppose. So once we get things eased out, maybe it would be, we would be able to opine a little better whether we put it up as a success program, or it's too early to declare either one, whether it's a success or to write it off as a failure. We need more time to see that it gets implemented and then watch how it evolves. Thank you.
Wonderful. If I can add some things, Animesh, wonderful. You touched upon all the pertinent points. If there's something I can add, I think moving from the prescriptive nature that NMC started off, then they slowly started realizing one size does not fit all, and they're becoming a little bit more accommodative of regional variations. That is a welcome sign. Somewhere down the line, state governments and DPHs also start getting involved to various degrees. So the workforce of DPH, the health care infrastructure available at PHCs, we need to work along with them. I think that is still a work in progress, but I guess that's why we have such programs, and we'll see where we can take this. I'm quite optimistic generally. Thank you.
Yes. We all are, sir.
Nice.
Good evening. Good
Thank you,
evening,
sir.
all. So, as my part, I have a different story to tell, that in Kerala, in our institution, that is in Amala Medical College, we had started this family adoption program little bit earlier. That is in 2013, we have this program in our medical college. And at that time, I was a first year PG in the same department. So initially what we did is we had a preparatory phase. That is, we identified a panchayat near our medical college, and our health inspectors and MSW workers have went to this panchayat and adopted one ward and selected the houses as a pre-preparatory phase. And then during the phase 2, when the MBBS, that is, this phase 2 means this after CBME, that is before CBME, when they come for second year MBBS posting, we have this clinical posting. So during that time, we take the students as a small batch, around 25 to 30 students will be taken out, and we will be giving, at that time, we were giving 7 houses for one student, and we have a performer for taking the socio-demographic characteristics of the family, as well as one performer on the clinical examination. So once they had finished their medicine posting, they are well versed how to take history and how to do a clinical examination. So the students during that time, they were really happy to find an individual or find a household member to demonstrate whatever they had studied. So actually we were given this BP apparatus and other weighing machine, etc. And the students will be taking the clinical examination part, and almost 5 to 7 days will be given for this family adoption. And once they come back, 1 day is given for data entry. And we have a small computer room containing around 10 computers. So 3 students per one computer will be sitting and doing this data entry for 1 or 2 days. And after that, we teach some element of statistics to compile the data regarding the age, gender, the socioeconomic status. So they will be learning the little bit of statistics of calculating the mean, the proportion, everything they will be doing with the help of statistician. And at the end of the posting, we ask the students to do a presentation on this small families on that end of the clinical posting. So that was we were doing. And when CBME announced this family adoption program, actually for our medical college, it was easier. And we still now we are incorporating these stages. That is, preparatory phase will be done 1 month before the clinical posting, so that the health inspectors will be going to the field and recruiting the houses. And in the implementing phase, we take the students to the field and doing the family adoption. And when they come back in the 3rd year, that is in phase 3 part 1 also, the same houses will be one or 2 days will be given for the field visit. The same houses they will be visiting again, and they will be making a rapport. They will be giving some health education sections, and medical camp will be done during that time. And these are the things that we were used to do. And when you talk about the outcomes, I want to tell the 3 important outcomes that the students are gaining. That is the curricular component. Under curricular component, they are learning about how to interact with the families. That is, the communication skill is the most important thing they are learning from the phase 2 onwards. Then the clinical skill, whatever they had learned from the clinical posting, they are getting a good individuals which are apparently healthy. They can practice their clinical skill and they can make it thorough. And the third thing is research component. That is, they are doing some kind of the statistical analysis at the baseline. And we are taking these families again for taking the UG projects. We take certain data from this family adoption program and giving small topics for as a UG projects when they come back in phase 3. So these are the important outcomes that we are getting. And in Kerala, what we find is the students are really, the majority of the students are really enjoying this program. But when you come over the generation, I think there is a generation gap nowadays that some of the students are finding reluctant or not willing to go to the field, some students. But as a faculty, what we need to do is we need to motivate them, and we need to provide a proper guidance so that we can overcome those challenges. So in next section, I can continue what are the challenges what we are facing. Surely we had challenges. Till now we have challenges that we can have another section on discussing the challenges and the solution. Thank you.
Thank you, ma'am. The journey of your institute is quite interesting to know. When we talk of the FAP, Family Adoption Program, I feel there are 3 important pillars: faculties and institute. The second one is the students, who are the recipient and the biggest beneficiary of this initiative. And third is the stakeholder, villagers, and the village itself. So, first, moving with the faculty point of view, I would like to ask Dr. Hemangini, madam, that can you enlighten us about what strategies or institutional supports actually helps sustain the faculty motivation and engagement in the family adoption program, as it discussed that it is a sometimes very tiresome and demotivating one. But how which strategies can help faculties be motivated for this, and engagement can be enhanced for faculties.
Thank you, Dr. Mohit. You very rightly pointed out the three pillars, but I would also like to add a fourth pillar of the parent component. So the parents are also one aspect that we should look into. Now, as far as the strategies are concerned, it is definitely very, very important that there has to be a institutional prioritization given to the program. Without that, it's definitely something that is not going to take off, and it needs a strong leadership who is going to be owning up the program, not just it shouldn't be just a departmental program, but it has to be owned at the institutional level. Now, I have seen one example in Tamil Nadu where they have actually taken an initiative. The Department of Medical Education and Research has taken an initiative, and they have brought up a document called Community First. Now, if you look at that document, they have involved right from the principal secretary, from the top till the student, and all the health workers. So you have an entire, hierarchy which is involved. The top people are at the advisory level. That you have the very, very nice this that they had made is a state program advisory board. There is a program management unit which is there below that. After that, they have taken it up at the district level, the district program. They have then divided it into field units and sectoral units. So if you can get a hold of the document, maybe we could share it later. It actually has devised the roles and responsibilities of every unit that has been established. There are people who have been made coordinators, and what they have done very well is they have entire area, the district at the district level. What they have done is they have done geofencing. They have mapped the entire area digitally, and they have laid down areas which are assigned to the colleges. So it is the district level which assigns the areas to the student, to the colleges, and the colleges are also given the number of students. They have around a huge number of students which are there, are all divided in the various colleges, and it is they who direct the colleges of how to go about it. They even have small sectors which are involved, like you have 20 students, and then they will be having that particular area will be headed by a sector unit. So there is some kind of a very, very strong top to down approach which has come up, which is, I feel, good, because when it comes from top to down, it is definitely something that needs to be followed, is what the message goes across. Secondly, what happens is we are only medical colleges struggling with the family adoption program, whereas in DRP or in the health and wellness centers, the Arogya Mandirs, there is a very strong participation or collaboration with the Directorate of Health Services, which is missing per se in the family adoption program, and which we have to initiate from the college level and start off. So that, is like it all depends on your relations or your goodwill and how the things work in that particular area. So if we have a kind of, there are two parallel systems, medical college and the Directorate of Health Services. So if you have a kind of a connection between the two, then you have a track which can run, even better. So stakeholders, everyone should be on board, and it is very important that they are taking it up in such a way that the dedicated logistic and administrative support is provided. There has to be a leadership commitment, and the commitment that is given has to be shown in action in terms of providing institutional support. As far as the students are concerned, they have to understand that this is going to be part of their curriculum. It's not some offhand separate program which runs, and it is part of that, and is very important for their assessment. The attendance part of it, we need to make sure that the parents are also involved, because now with the NMC coming up with remedials, it is very difficult for students who have missed FAP postings to get remedials in that. So there has to be an undertaking taken from the students, that and the parents also, that they are aware about the compulsory attendance that is required. So all this is definitely very essential. Now, if you look at the family point of view, there has to be something that should be provided to the family. Many of the students, the colleges have started university health priority cards or health priority cards, which are given to the family members of these adopted families. So whenever they are having a treatment seeking at whichever level they go to, they show the card and then they are sort of, they do get a little kind of a priority, not terms in terms of maybe finance or anything, but a kind of they'll get seen looking at the card. Maybe they may be given a kind of special this uh, attention in terms of seeing them early or something like that. Some benefit is to be given. The camps have to be conducted in such a way that the locals are benefited by the medical care that is given to them. There has to be some kind of a change, because what happens is otherwise we're only taking from the community, we're not giving back anything. So that is something we definitely need to do it. And socially, we need to have we have to demonstrate community benefit. It shouldn't be just like a one event. Otherwise it's like one event, we just do one event, there is a lot of photo, there's a lot of everything happens, it's put all over the place, and that's the end of it. But at the end of the posting, if we generate a report that what are the observations and what we would like to get attended to, and have the concerned departments intersectoral coordination, we should be able to try and make a difference, is what I feel. And there have been definitely key outcomes are there at the surface value level. If you see, you can definitely see the students understanding the national health programs implementation much better. They have a understanding of the health seeking behavior. They have deep insights of social determinants which are coming up and playing a role. They are learning how to build a rapport. Families are also more accepting. There have been research papers also which have documented this at the family level also as this. But like I said, it's still early. We need to generate more aspects to be able to understand the impact in the actual sense that we are talking about. This is just like, the immediate results that we are seeing. Thank you.
Thank you, ma'am. You very well enlightened about the Tamil Nadu example. That top to bottom approach is increasing the faculty motivation to run this family adoption program in their institute. It actually facilitates a lot. I would like to ask ma'am if you know any such other strategies or models that are being implemented in other institute or other states in your knowledge that are being successful, and it is increasing the faculty motivation to run this FFAP in their institute. If you can suggest a few other models or strategies that you know about.
We have many, sir, but it depends on what you're looking at as the successful. Each one has a little bit and pieces of which is running good. So that way it is difficult to point out. But if any college has some, a new innovative aspect which is running well, then that definitely gives them a little edge over running the program. Faculty motivation definitely is very important, but what I feel is if the infrastructure and logistics are taken care of, then half the problems of the faculty are solved. More than half, I would feel. So it's the energy that of the faculty which is gone in just getting the infrastructure together is very difficult. So we have stories like in Jamnagar also, they are doing such wonderful work. They have 250 students and they're giving 5 families to each student. But what they do is they rope in everybody who have, I mean, all the nursing, the dental, the buses are taken together. And it's like, that's how you need to pool your resources and try to put it across. So once that is in place, the faculty definitely can, not have to worry about all this logistics, and then they can focus on the actual teaching part that is there. We also need to motivate the faculty in terms of academic recognition, that wherever this reports are shared, the names are announced as to how the coordinators have worked, they need to be appreciated. So even in their APRs, a lot of mention can be made of how well they have done the program. They can also be sent to other institutes to be able to observe the programs in the other, there can be exchange sharing. So a lot of measures can be taken up that way.
Thank you, ma'am. You very well said that if the infrastructure and transport and other management are taken care by the institutes well, it's more than half of the burden of faculty is managed well. Very well said, ma'am. Uh, Thank you, ma'am. Now I would like to ask Dr. Sitaraman sir. Uh, Moving on to the second pillar, like how can FAP be effectively aligned with the CBME framework so that it becomes the integral part of the learning? Sometimes it has been observed that the learning outcome and CBME frameworks are not aligned with the program. So, in your experience, in your observation, what do you suggest that how can FAP be effectively aligned with CBME framework and
Okay.
learning with FAP can be enhanced?
Okay. Thank you for the question. I think we can start from where Madam left off. In that DMER Community First initiative, the district collector is the chairperson of the district level committee. That shows the commitment. But let's see, it has to run for a few years. Then we'll. It's definitely a very structured initiative. It started last year, around last year. We are benefiting from it, no doubt. But moving on to this specific question, how do we align FAP? FAP in broad terms is actually already aligned. When we talk about, let's say, the first contact physician or the IMG being socially responsible to local needs or empathy, all these things, FAP lends itself as a wonderful platform to achieve these stated roles of IMG. We just need to recognize them and and move ahead with that. Anyway, still to make it truly integral, I think we need specific structural additions which we could list out actually. One is what Madam said in the beginning. This should be seen as an institutional initiative, not a community medicine department job. This is an institutional initiative, definitely. Second, I would say we should map our FAP activities to specific competencies and even certifiable skills. Most of them can be from community medicine, but definitely other subject competencies can also be achieved through the FAP platform. So if we show the students that what they do is actually linked to their overall competencies and skills to be gained, there is a higher chance of them being more serious about it. Then if we see, we can systematically implement FAP across different phases, which we already do. What I'm trying to say is, uh, see, in phase one, we have ECE, early clinical exposure, which actually has an early clinical exposure in community settings is a thing, right? Our document says ECE does not always need to happen in the hospital. It can also happen in the community, and which is where FAP wonderfully fits the picture. It can serve as an early clinical exposure, which many institutes are already doing. I'm just pointing it out so that more light is shed on this. And in phase two and phase three, we could link it more tightly with our clinical postings. As of now, it is a standalone activity. If we link it up with clinical postings, then students will have a connect. We have a chance to involve other departments, and we have tried creating some linker cases, real life cases, which we can use as linker cases instead of hypothetical cases, which NMC has given the diabetic antenatal mother. We have a list of 6 or so possible cases. We can do that with real life patients, and that's a platform to involve other departments also. And one more thing I feel is NMC should come out with a handbook. We have handbooks for most, alignment and integration. We have 8 handbooks, I think, 8 or so handbooks. Slowly, each one was released. It's high time for a handbook on FAP. I was told IAPSM is working along with NMC to get this done. That would be good. We definitely need a handbook. That's the official NMC version. But we, out of these conferences and all we hold, last year we actually had a conference on this. Some of our participants and moderators are also there. We were trying to come up with a compendium of sorts of the good practices, the challenges, and the way forward. We have it. Probably we'll soon publish it as a book. It's been kind of sleeping with me. I have to like go ahead with it. But anyway, so on my private sources, we do have documented, uh, collections of what are the good work, what works in that college. So once we have a compendium of that sort, maybe other institute can pick and choose what will apply to them and what will not apply to them. And finally, I think we need to learn to think beyond NMC. NMC has given a basic framework, but we could definitely improvise on this. For example, interns. Interns can definitely be involved in FAP. I'm sure we are already involving, but it hasn't found an official sanction. I think community medicine interns can definitely be linked, and probably they can follow up the same cases they did, or a new case with the new batch that is going on. Interns have more to offer to the people than first year or second year students. Or if you extend that logic, you can even involve postgraduates in. See, they need not be actually allotted 5 patients, and we don't have to do everything that the FAP model says. We need to look at FAP as one of the models of community-based learning. If we look at that broader umbrella, I think we have place to involve interns, postgraduates from other departments also, not just community medicine. Right. So these are my thoughts on how to meaningfully integrate this into the curriculum. I could hear from other people also. Thank you.
Thank you, sir. I would like to ask one more question to you. You have very well said about uh, competencies and certifiable skills. It will increase the interest of students in FAP as well. So I would like to ask that how can assessment or reflection of FAP can be integrated in this process, which will enhance the interest, and the FAP can go on a long route without any hurdles. So your thoughts on reflection and assessment process of FAP?
Okay. I think assessment and reflection, we can look at it as slightly two different answers, maybe. We all know assessment drives learning, which basically means students will take it seriously only when they know they're being assessed, right? But FAP, to start off, is a bit tricky because there's a lot of affective domain involved. Difficult to assess the affective domain with our usual tools. But still, many of the practical applications that they do can be measured. We just have to put in more, thought processes and planning. It can be assessed definitely. To to start off, we could moving on to slightly the reflective component. We should encourage students to do reflective entries, right? What they actually feel. That we found was much lacking actually. Now, reflection as such is not something they can start off straight away. It takes some practice, but they can definitely be trained to do reflective entries, not just a checkbox to fill, not a very dry logbook entry. Can actually be like live with your like feelings and thoughts, like your Insta reel, something like that. We need to speak in terms that they understand. So if we can breathe some life into their documentation, they will be more involved. Right now, it's a very dry, um, logbook. That happens with most of the things which, if given from top down, they just look at it as one more book to fill, one more box to tick. So if we can take that out and replace it with the more organic reflection, it will work. But it needs more work from our side, training them in reflective writing and all. Now here's where e-portfolios can be helpful. Instead of a very very strict, straight-jacketed record book. If we kind of let them have the freedom of journaling, like a portfolio, electronic portfolio, they can attach their photos and it is, they will feel that it is their work instead of one record book to be submitted next week for correction. That shift, if we can bring, that will be nice. But now, circling back to the assessment part, we can assess, like for example, if we know Kirkpatrick's model, right? We can probably assess their reactions, and maybe the stage 2 of learning can be assessed. But the behavior and the actual, change or the outcomes that come about with these behavioral change, they are difficult to measure within the time period that we are keeping the students for. So yeah, these are some of the challenges in assessment and possible choices of assessment that I can think of. Thank you.
Thank you, sir. I found it very interesting that you talk of communicating with students in their language or the language they understand. So, not being just stick to the one more journal or one more checkbox or one more few pages of journal to be submitted, but a more relaxed version of that. For example, journaling you said can be adopted to increase the interest of student and parallel assessment as well. There can be a good way of reflection from the student. Thank you, sir. Uh, moving on ahead, I would like to ask Dr. Shruti ma'am that what challenges do students face in the maintaining continuity and interest in the FAP? You mentioned about the your institute experience. Would like to know about what are the challenges that do students face in maintaining the interest in FAP, and how a faculty or a mentor can address this so the interest during the FAP lasts longer.
Thank you, Mohit. So, as the question is, what are the challenges the students are facing to maintain the continuity in FAP, right? So, actually, the students I had mentioned earlier, some of the students doesn't have an interest in doing this FAP. So, we need to consider their age. They are young adolescents, around 18, 19, 20, 21 years, and merely they were, when we tell them to go to the field and collect the data, actually it is little bit boring process. So what, as a mentor or as a faculty, what we need to do is, as Raman sir had mentioned earlier, that the effective domain is the component that is assessing in FAP. So we need to motivate the students regarding what services the students in FAP, what they are going to do apart from collecting the data, what the family, how the family is benefited. So when I have a class on FAP, what I ask the student is, as a medical students, have anyone had done a blood donation? So mostly in the first year, neither one of the student will have not done any blood donation. So so I start that with my class with that. So so I will be asking next question, why as a medical student the blood donation is the most important service or most valuable service as a medical student that you can do, and why you have not done till now? So you have a service component, you in that is an FAP program that you can serve the community, serve the needy people, those poor people that actually need help. So as a mentor, we need to motivate, and we need to motivate the student to go to the field and do this service component at least during their MBBS days. So we also do some kind of what spiritual motivation, or mentally ask them to, so if you get that, if the families are getting some help from you, from your side, that family will be remembering you in their daily prayers. So this prayer is enough to pass the MBBS and to get the PG seat. Like that, we motivate the students. And in Kerala, we have a terminology known as Kaipunyam. I don't know what is the English word of that. That is, even if the doctor is having proper clinical skill, proper communication skill, that doctor will not be having enough patient. But other along with clinical skill, along with communication skill, whatever that you are doing with your hand, that God's grace need to be on your hand, then only the patient will be having the curative cure. So that thing need to get by giving that skill will be getting only by doing these services. And other component by how to increase the this interest among student is, apart from data collection, we need to do, that is we are doing like vector survey. So when they come to phase 2, we same families, now we are taking only four families. So in that 4 families, we do a weekly dry day. One day is posted for vector survey, and weekly dry day, that is they go around the house as well as inside the house, and will find out is there any that water holding containers or plastic things outside the house. And they will what they do, they will collect, they will discard all these material, all these plastic materials, and educate the household members how to make it daily weekly clean. So, and what they do is we divide the 30 batch into 2, and we ask them to do a presentation on Laval indices and what they had done. So nowadays the students are always having their mobile. So initially from the phase 1 onwards, I asked them to record the videos, whatever they are walking, whatever they are doing, so that once you finish your MBBS during your convocation, these videos are the most lovely videos, and these are the days that you enjoy in your MBBS life as the most enjoyable days. So that they will take all the bits, all whatever they are doing, they will record in the video, and they will compile with actually the students are more better than us in digital world, so they have so many sorts of apps and all, so they will combine all these small videos and things, and they will exhibit along with our HOD. We during the end of the day of the posting after the exam, we have an half an hour to show this videos, and we put a mark for each team. We divide into 2 teams, so that one dairy milk or one perk will be given for the winning team. That is one box of small perk will be given as a gift. So that is our HOD is doing, so that it will motivate the student and recognize whatever they are doing, so that they will be getting more motivation. Other activity that we incorporated is medical camp. So on all in phase 2 clinical posting, at the end of the family adoption program, one day is for vector survey, the next day is for medical camp, so that around our management is providing around 2000 rupees free medicines, essential medicines, so that we could get these essential medicines, and we can give these essential medicines. And our PG students will be examining the patient. One faculty will be allotted, so along with our PG student, if possible, if house surgeons are available, we will take the house surgeons also, and we do a medical camp, and it is completely organized by the students. So they will go and visit the houses allotted for them, and they will ask the patients to come and check their BP, and also the GRBS is freely done. So they will learn how to take a GRBS in a glucometer, and take the values. And the thing is that newly detected, as you know that the Kerala is the diabetic capital, we have individuals with random blood sugar more than higher values, and we tell them to visit a hospital, so that they are detected through these students. Even the hypertension is also having higher prevalence in these areas, so only when the students are checking the BP, we are getting that they are knowing that they have hypertension, so we can start the treatment for this non-communicable disease. And one health awareness section is also given. Students will be preparing charts, and they will be executing that health education. So all the medical camp is also taken, they will be taking as a small video, and they will be posting in the Instagram and Facebook pages also, so they will be getting likes. So digitalization is the one of the important thing to increase the students interest, that we are following now. And the second point, as already mentioned by Sidaraman sir, that is portfolio. So we incorporated that portfolio in for 2022 batch. So what we had done is we had asked the student to prepare a hard copy of the portfolio. Not only the family adoption program, whatever we have other institutional visits also. So wherever in the community medicine, wherever they had visited, you have to keep a photo and print out a photo, and under that write 2 or 3 sentences on that visit. So when I look the portfolio, we have a mark, 20 marks is given for that portfolio. So I think that it was done beautifully by students. They have these ideas, and they had all these photos were there in their phones, and they had they had taken the printout, and they had given a write-up. And this portfolio, I think for those students who are preparing for PLAB exam and USMLE exam, this community-based learning is one of the component. So they can actually submit this portfolio to this PLAB and USMLE exam. So along with their research article, this community-based learning, they are asking whether they were doing any health education section. And for them, all these things are very important. So I asked those students to keep this portfolio along with you so that you can submit for your interview purpose and all. And the other challenge the students are facing is the time of visit. So what they are telling is usually our posting starts from 9 a.m. And when we take the student from 9 a.m., the students will be reaching around 9:30 a.m. in these families. So in Kerala, what the situation is, mostly both the husband and wife will be working. The children will not be there in the house, and so they won't find anybody in the house. That is the challenge nowadays we are facing. Only the elderly couples will be seeing inside the house. So what for overcoming that challenge, we could not follow, or we could not change the timetable. So what we had done is, we had asked the students to visit during the evening time. That is not from the department, from their own, along, make a pool of friends and visit that area during the evening hours, and call the family when they are free, and visit the family. So so when they are going in a group, I think they are also enjoying. So when they are free, that is when they are after 4 o'clock, anyway the students are free, so they can go to the area, that household, and they can have a tea. And mostly the families are welcoming, so they will call the students to come and have a tea and have some snacks. So they are also happy, and the students are also getting the interaction with they are also getting the data collection is easier for them when they go for evening. So that is the other challenge, and we overcome this challenge by asking the students they to do their own visits after 4 o'clock. And our hostel is also very strict, so they need to come back before 7:30 p.m. So anyway, till now we don't have any problem. They are visiting their own. Mostly they are visiting in those houses where the people are not available. They are going during the evening time. And as all colleges, that is logistic challenges are always there. That is transportation facilities are not. We don't have a very big bus accommodating 50 or 100 students. So we have usually for community medicine visits, they provide only small bus accommodating 30 students. So in phase 1, that is a problem that we are encountering now. We cannot take whole 100 batch students together. So what we do is we split up this batches, and other only 30 students will be going to the field, and other batches will be doing other visits or other water treatment plant in a hospital. They will be visiting hospital waste treatment plant. So short visits will be done for other batches. So like how we are managing in phase 1 this logistic difficulties. And another challenge the student is facing is the public is expecting the curative services from a medical student rather than a preventive service. So that is the biggest challenge that I also face, because they are a first year or the second year or third year student. And one student had called me last year, that is from that adopted family, one mother, 3-year-old baby's mother had called that girl and asked how much dose of paracetamol need to be given for that child. That child is suffering from fever, so they are considering them as a doctor, full-fledged doctor. And so that child is anyway the second year child, phase 2 child, does not know how to give how many doses of paracetamol syrup need to be taken. So so what I tell in phase 1 itself, that is, if they ask any doubt, if the family members are asking any such doubts, please ask them that I will call you back within 5 minutes, and call your mentor or any faculty to clarify this doubt and give them a proper guidance. apart what they know might be wrong. So don't give a wrong information. Anything the families are asking you regarding the doubt, please call the mentor and tell the right or guidance about it. So these are the challenges that we had done. We have faced it. Nothing more. I think the other persons can add on. Sorry, Mohit, your mic is mute.
Okay. Hello. Thank you, ma'am. In enlisting the many of the points that you brought up, few were very interesting one. What Sitaraman sir said that talking with the students in their language, because the new generations are tech savvy and digitally literate more than us, and the micro bloggers and the new students are very much popular. So documenting their journey and the FAP in a digital format is also increasing the interest in the students. So it caters a part of the students, and the portfolio creation in the FAP also caters a different sort of students who are USMLE or pleb aspirants. So it is quite interesting way you are dealing for the FAP. Thank you, ma'am. We also came to know about the R ARCH program, R program run at your institute. So could you enlighten us more about that program and how it is impacting the FAP in generally? So please enlighten.
Yeah, ARCH program is the expansion is Amala Rural Community Health Program. As I already mentioned, our family adoption program is known as ARCH program. So it was started in 2030. So we are adopting families from rural area. That is the Amala Rural Community Health Program. And apart from that program, we have also started an ARCH clinic in a hospital. That is, once a student is finding out any abnormality in the field, any patient with any disease in the field, that student can refer that individual to our clinic, Arch Clinic. So it is from 9 a.m. to, it is run by postgraduate student and one faculty is supervising that clinic, and it is run by from 9 a.m. to 1 p.m. So when the patient is coming in that clinic, we provide a free consultation only for those adopted families, family adopted, those patients coming from family adopted program, and free consultation. Along with that, essential medicines are given free of cost. And once you find that this problem is not manageable under a setting, you can also refer to a specialty in a department, and that referral is also free. But from the specialty, if the specialist is writing some medicines, they need to buy it. And if the from the specialty, if they're doing any investigation also, they have to pay for it. But the 20% reduction is given for those patients who are having inpatient admission. So that is the thing, that is a follow-up from the field, how to do a follow-up in the hospital. Otherwise, what happens is that if you find any disease, if you cannot manage it, already told that the curative services, the public is more interested on curative. So we need to provide something for them. Otherwise, that will be the follow-up will be lost and they won't provide any interest. So we started like that. The Arch Clinic is still running, and the problem now we encounter is since we started the family adoption in 2030, nearby all villages we are already adopted. So now we are adopting a faraway village, and last year we have no patients are coming to Arch Clinic for getting any service. That is a last year's status. But from 2013, nearby villages when we adopted, almost 10 to 20 patients are coming monthly wise, and we could provide services for them. But actually the distance is the matter here. So now we don't have, but Arts Clinic is still running, and we provide free treatment for them. And IP patients are coming to our hospital from the adopted family, so they are giving 20% reduction in the bill. And as ma'am had mentioned about the card system, so actually we have not started that card system. It is in the planning stage. But once you come to the Arch Clinic or for the IP admission, the students or the faculty in charge who is going to the field visit will be writing in the prescription pad they need admission, and they put the signature, so that once they come for the in a hospital, once they show this thing, that is the identity card that now we are using. So in future plan, we have this priority card. We are developing it, but we still now it is not on the process. And apart from that, we have from this arts clinic, apart from that, we have another thing known as Sanjeevani clinic. That is most of the departments will be having sample medicines. So it is an initiative started by the students unions to collect. It is completely run by students union. So they will collect once in a week. They will collect all the sample medicines from all the OPDs, and they will it is near to our arch clinic, next room of our arch clinic. So they will store this medicines in a shelf, so that if any student is finding that the family member, adopted family members need some kind of medications, especially for chronic diseases like diabetes and hypertension, they need a lifelong medication. So they will come to the this Sanjeevani clinic, and they will check whether these available medicines, sample medicines are available. And I told Arch Clinic is run by a PG student, and one faculty will be there. So they will cross check before giving to the patient what is the prescription and what is the sample medicine, is it safe, and then they will give to the families. So that is also running smoothly now. So the community medicine department is supervised the Sanjeevani clinic, but it is purely run by students. So when during the lunch break they come, the students will be, I think they have a rotation wise posting. So 5 students will be coming and sitting during their lunch break in the Sanjeevani clinic. And from the IP patients are coming and getting these medicines. And our hospital staff, the cleaning staff are also getting free medicines from the Sanjeevani clinic. Apart from that, the adopted families are also getting, some of the members are also getting benefited by the Sanjeevani clinic. Then what I want to tell is one of the others Arch program is also doing the service component. That is, we are doing at the end of phase 3 part 1. That is, after their model preliminary exam, we are conducting a mega camp for all these adopted families. So mega camp means 1 day full program. And what we do is we identify what is the actual problem. The social determinants are taken care here. So what is there any bedridden patient, or is the patient needs wheelchair? So medical equipments, if they need any medical equipments, with the help of the management, the students also take some money. The 100 batch students will be contributing some amount of money, and they will contribute, they will provide a service to the needy family. So it is fully, the which family needs help is told by the students. So out of these 4 families, if any family need help, they were helping to build the infrastructure of the house. Some of the houses will not have a proper roof system, and they provide money for building the roof. Toilet facility, the European type of toilet, the elderly individuals are living, they don't have a European type of toilet, so they are providing money for building toilets. So this is a service component that is not incorporated in CBME curriculum, but as an Arch program, we are also having this service component. And really, I think the students are really involved in the service component. So they are more interested in how to serve the community, how to do a proper service for those who need it properly. So they identify it, and they, with their money, with the help of the management is also funding, some amount of money is management is also funding, and they take this program. That is, we name the service component as Nanma program. So Nanma means to provide good or provide service to the community. So every year we conduct this Nanma program, and we start the program with a mega camp involving all the departments, and in the afternoon we provide this service. And our management will also call for the program, and they will distribute all these things. So actually for the institution, it is a program to exhibit. They, the next day they will be having photos will be given in the paper that the Amala medicines are given service to this population, etc. So actually it is an advertisement for them also, and it is helping our students also. Thank you.
Thank you, ma'am. As this Sanjeevani clinic is uh, uh, managed by the students, so the ownership comes with such initiatives. So very interesting initiative by your institute along with the FAP, which is also strengthening the FAP as well. So thank you, ma'am. Uh, moving ahead, I would like to ask Dr. Animesh Jain sir that we are talking about FAP. So the one of the important pillar, the stakeholders in the FAP. How can community stakeholders be meaningfully involved in the FAP? So this FAP can be sustainable for a longer duration. So please guide on how community stakeholders can be meaningfully involved. Animesh sir.
Am I audible?
Yes, sir.
Yes, sir, you are audible.
Okay, something happened, so that's why that Zoom,
you-
that's why. I don't know, it was freezing, so I tried to rejoin. Okay, as long as I'm audible. So it is a very good question, Mohit. The thing is, see, if we have to succeed in this program that is FAP, we need definitely a sustainability and long-term kind of a engagement. At the same time, we have to also understand that there are certain things which hamper this kind of a long-term engagement. And if at all we have to do this, then there are certain things which we need to do. So obviously, if we need to continue this and build trust, we need to have more engagement. It obviously has to also have some benefits built in for the community and the family, not just for the college or the students or as a part of the curriculum only. And it also helps us in building the credibility of the institution. Having said that, there are some functionaries which are already on the ground. So there are people who are working in the community, ashas are there, NMs are there. So those can be onboarded, one. And they can also be involved as sometimes as co-mentors and for the students, because they know how to, what's the pulse of the community. So what happens is they can actually help and guide. Of course, we can't burden them further. I'm not trying to suggest that, but at the same time, they can be brought in for some times or some of the kind of discussions, and or they can be even involved to go around along with them, so that initial stages, so the students see and learn from them. Having said that, we can also do one thing is, which I saw, like, and I learned at Sevagram, what they do is, before they go into the community, there is a lot of planning which takes place. So there is already like a discussion with the local self-government, that is the panchayat, the elders and others. So they have to be brought into the picture. So that has to be taken into account, and then also look at what is their need, because sometimes in any program, not just FAP, when we go in, we think in our terms, but we don't realize what is the need of the community. So need to get them to also spell it out. And another very important thing is that there should be periodic mechanism where they can come out and give us feedback, because we might be thinking we are on track, we are doing right, we're doing very well, but then maybe there is some kind of a alignment or misalignment. So it's very important that we open such channels, and that will also build further trust and credibility, and also a long-term sustainability. So these are some of the things which can be done. We also can try and integrate it into, see, many of them have these centers, or even sometimes they have certain days, or health and nutrition days. So these can be also brought in such activities also can be in tandem with the activities of those planned programs. So that can also be done. And we can also think of some students, or even some of the community partners who are helping us, they can be given recognized or acknowledged once in a while, or maybe say at the end of the, say, semester, or maybe at the end of the year, where we have actually tried to recognize them as maybe with a certificate or something, or even try and give them some kind of a say FAP champion or FAP ambassador or something like that. So that could also be helpful. So these are some of the ideas that can be thought of, because otherwise it will not really actually work. So we need to think of some kind of a thing like this. Of course, we've heard from Dr. Shruti and some ideas otherwise also. So all these, some of these thoughts are there where we can actually engage. And it's very important for us to engage with the stakeholders, that is the family members themselves. Because if we don't do that, definitely it's not going to work out. So we need to listen to them. We need to be patient. And that's the reason I'm trying to say that, medico social workers and also the ASHA workers and the ANMs will play a very, very important role, because they know how to deal with, and our students sometimes are not so matured or not so say well versed with these things.
Thank you, sir. You brought a very important point that when we are organizing FAP, we take help of local leaders and the health staff, MSWs or ASHAs, ANM that working in the ground field, and they are well aware of the situation or the local community. So we can incorporate them occasionally without burdening them on a regular basis, and also not just taking help of them, but also recognize their work in the form of FAP champion or ambassador is a very interesting suggestion from your side, sir. And I would like to answer. I would like to one more question that to make it more sustainable, would you suggest any other strategies which can incorporate it from ASHA to the local panchayat leaders, from community leaders to local leaders to make it more sustainable? Apart from what you already said, more strategies to strengthen this.
So maybe what we can do is, see, we can also have something like a letter of collaboration or something like a partnership. See, we need to give them that importance. See, and the other thing could be, as I said, let them have more say into what they want. So every time we do it with different batches, it could be probably tailor made also to suit some of their needs. So then it becomes more meaningful for them. So I think that could be done. And let us also sometimes try and involve, there will be some other organizations, there may be self-help groups, there may be youth clubs. So we can have some activities, tie up with the youth clubs, do some like we can make them do some of the activities together. And then as a part of that, there could be some of the checkups, like Dr. Shruti was talking about health checkups. So we can have checkups along with them. I'm not sure if I'm still audible. Yeah, I hope I'm audible. So,
Sir, you're
so
audible.
some of, yeah, okay. So some of these can be done. Self-help groups can come in, and then we can arrange along with them. We can arrange some of these health education sessions. So some of these things can be. I do see that the involving health ASHA workers is difficult. Not necessarily. I think it depends on how do we have the rapport, and let's try and involve, because here I've seen that many of the places it does work. Yes, as I said, we can't overburden them, but it does work. So I think it is possible. How do we approach it? It's possible. So these are some of my suggestions or thoughts as of now. Uh, there is like a lot of possibility, but again, each place will have its own challenges. Each place will have its own opportunities. So we can't have one size fits all approach. We will have to modify. We will have to learn from different experiences. And another thing is we need to share. I'm very happy that Dr. Urvish has actually shared that article. That's a very good article Dr. Urvish and Dr. Sharon have authored, which he has shared. But I think there are more opportunities for us to come out with our experiences and share that and publish that. Then only we will be able to these forums are good, but I think we need to also build evidence and credible evidence which is required, and share more so that people start knowing what's happening. Otherwise we are working in silos, we are working in our own pockets. So thank you.
Thank you, sir. Uh, I like I like the sentence you said. What is their need? Ask them. So when you said that, it reminds me of the Dr. Abhay Bang and Dr. Rani Bang's initial experience during coming to India and doing so many things for community. So these were the similar experiences of them. Then just on our own perception, we start serving something, but maybe the community has some other needs. So asking them and to understand them and act accordingly would be more beneficial. Thank you so much, sir. Now, quickly, I want one question, one answer from all the panelists. That what are top three elements? What are the top three essential elements, in your opinion, that are most important in sustaining the FAP? Just quick three things that you feel that these are the crucial things, most important things that are needed for sustaining the FAP. quickly from all the panelists.
So if you don't mind, let me continue then, Mohit, if it's okay with other panelists as well.
Sir. Yes, sir.
So it is very important. First is, I always keep saying in many of these things, and whenever we do something different, one is the mindset. Everything boils down to that. Many times I find that we ourselves are not convinced, we don't have the mindset. How are we supposed to motivate the youngsters? So I think it's very important that we have the mindset, the right mindset, and we believe everything will fall in place. So that is one. Second thing is, of course, we need to have like listening. So it has to happen, and that means we need to partner with community, partner with local organizations, and show them what's in it for them. Ask about their need, but also that what's in it that we are going to give. And then the third thing, very importantly, is obviously the budget and the finance and the logistics to be provided. How we work it out and all, it's very easier said than done. Maybe some way, Dr. Hemangini was mentioning about some examples. I think that's a very good, like DRP or whatever things, so centralizing or something. But then we need to look at that. So these are the quick three things that I could think of. Thank you.
Thank you, sir. Hemangini ma'am, if you can give your top 3.
Ma'am, you're muted.
You're muted. You're muted.
I would definitely say leadership commitment, so that there is a dedicated head for finances and all the infrastructure and support is in place. Academically, we need to have well-defined objectives and competencies that we are going to be looking at, and we should have structured, assessment for the program as far as the students are concerned, and use of technology so that all the burden to collect the data is eased. So the collection and analysis goes in hand. And as far as the community is concerned, socially, we have to definitely have something to give back to the family. And also, they should be sensitized earlier about what the family adoption program is all about. So, if you want to put all these three things together, like I said, we have to get the Directorate of Health Services along with us in this movement. Otherwise, this is like somebody else's domain, this is your domain, and there are no connecting tracks in the program. So that would really help us.
Thank you, ma'am. Raman sir.
Yeah. My top 3 would also resonate with what we have said already. I think my first one is we need to work along with the health services which are already in the society. If the PhD medical officer doesn't even know that there is something called FAP and students are coming to that area, then we are missing out some major thing. That will be the first one. And next, student safety and what does the community get back? These two are questions that have been like kind of bothering us from the beginning. We need to, we need to carefully work out solutions for this. I think that they still bother me. How do we ensure student safety and what does the community get back? I think these are my 3, top things. Thank you.
Thank you, sir. Shruti ma'am.
Okay, my top priority is the first one is institutional commitment. That means the CBME had already launched this family adoption program, but it is not only the community department, community medicine department need to do. It has to be done by the institution, so that other problems like logistics and other budget, all these things will be taken care once the institution is sensitized as that the family adoption program is a good program, and the institution is also gaining. So even I am working in a private institution, so they should understand that the patient load can be increased by doing this family adoption program. So we need to sensitize the institution regarding the importance of this family adoption program. So institution involvement is the first thing. The second thing is the faculty commitment. The faculty need to motivate the students, and the mentorship program can do that. Overcome this students' interest. The faculty need to motivate the students on the family adoption program. And as per the students' involvement, already the CBME had given the guidelines, like the family adoption program need to have an 80% attendance, and it is involved in the assessment part also. So the students will be anyway, if they are not interested, they must do it. So they will be doing their respective domain, and with their skill they have to do it properly. That is the aim. The faculty need to motivate the student. The third thing is the involvement of community leaders. ASHA workers, I think it will be difficult for the ASHA workers to work along with this family adoption program. But in my experience, the community leaders, once you get involved, once you talk the community leaders, they are more interested in this doing this service component. So once we do a medical camp, we ask the board member to come and inaugurate the medical camp. So they will definitely come because they know that community more than us. So the community leaders, the ward member, the panchayat member, the ward councillor, so they are more interested, more involved in that community. So once you do any service, even if it is a health talk, call them and ask them to do an inauguration, so that they are more happy, and they will be doing a 10-minute speech. Apart from that, nothing is losing from our part, and they are more happy. So that if we need any help, like if we need to get a hall for doing a camp, or if we need to get for mega camp, organizing mega camp and mega hall and all, they will help us. And they also find out the proper houses who need proper services. They also find out and they tell us what actually they need. So the community leaders, they can truly involve in a family adoption program, and with their help we can move forward, so that this program will be sustained throughout the MBBS course. Thank you.
Thank you, ma'am. Now I would like to involve the participant. If any participant have any questions, they can drop their questions in chat box. We can have 1 or 2 questions based on considering the time limit.
Dr. Mohit.
Yes, sir.
I am Dr. Mohammad Ghodke. I am working as assistant professor at IAME Medical College, Jalna, Maharashtra. So all the seniors, it was a very good panel discussion. I have one suggestion: if we could come up with the one broad competencies, SLOs, teaching, learning, and the assessment method, because we know that there is flexibility available, but that broad consensus should be there that this competency should be SLOs, teaching, learning method, and assessment can be covered in the 8 visit of first year, 8 visit of second years, and 12 visit of the third phase 1 year. So that will be easier to implement at the field level for the peripheral institutes. And the one innovation we have done is we have purchased 1 year subscription of the Qdwell app, that IIPSM project for 150 medical students and 10 faculties, which will be we will be enrolling the patients from next month onwards, and it will be a field-based primarily project. So that Qdwell that includes the maternal nutrition, breastfeeding, complementary feeding, and STD component is also there. Thank you.
Thank you, doctor, for your suggestion. If any question from participant, then we can take, or otherwise we can move for the conclusion.
We have been trying to, at least I have been trying to answer most of the questions in
Yes, sir.
with the
Thank you, ma'am.
background.
You have been actively engaging in the chat box to answer most of the queries.
Yeah. Still, if there's anything else, we would definitely know, because it's a very, very vast, topic. There would be so many things that need to be attended to. So what we
Yes,
have just provided is like an overview.
yes, uh,
And if
definitely,
I
ma'am.
may,
Yes, yes,
if I may
yes,
say,
sir.
I see Dr. Sairu Philip among us. If she can pitch in with a very quick 1 or 2 points, it will be wonderful. Dr. Sairu, you're here?
Yeah, thank you. Can you hear me? Okay.
Yes, ma'am.
Yes, ma'am.
Yes,
What I felt is that it is a bargain. Actually, for the first batch, I took a really needy area, which was slightly far away. The reception was very good. We could, we adopted the same way, interacted with the ward member and the ASHA. And first, the whole department made sure that they went to all the houses. Then they said that such and such houses can be excluded due to certain problems in those houses. So the initial groundwork was done by the department, and this was a difficult area. And because it was difficult area, the second batch we took in a very easy area that is right in front of us. But what I find is that the difficult area, for example, we matched the needs of the people with the services given by the students. First year, it is an area with paddy fields. So they have this, what you call that crack, that fungal infection in between the toes. So we made them distribute clotrimazole ointment. It is safe thing. Betadine ointment for cuts and wounds. That gave us a lot of acceptance. And it can be distributed by students as well. Then we linked with the district program. District, they were giving education on a program, Pradhirodham Pradhidanam, on leptospirosis, rabies and all. That we incorporated into the program. So that in all these difficult area houses, the message went. So it was sort of tailoring with the need of the community and the need of the district to that area. So acceptance was more, children, students enjoyed it more, but on the part of the faculty, it was very lot of work needed to be done. The second batch, we chose a very easy area right in front of us, but then the students were not that interested because all of the houses they had in Kerala, they were well-equipped houses. They had their own BP apparatus, their own blood sugar thing. So the second batch, I felt they were a little demotivated. And the third thing which we did, and what we did with the first batch was that we combined our community diagnosis in that area. We made sure that based on their needs, we formulated the undergraduate researches in that area. And the research is done where physical activity, then geriatric problems. So we could give to the panchayat a project book. So I found the first instance very satisfying. And what I felt is that 3 years is too short to do some changes in the community. So actually, we have handed over that area to the next batch so that the seniors can guide them. For example, I am a senior. I am linked to a junior. So the house is same. So any problem with that house, the junior can consult with the senior. I don't know whether it is acceptable in NMC, but for the students, they enjoyed it. And for camps and all, that senior-junior relationship was instituted. Now, let's see. Maybe after 1 year, I'll inquire whether that became successful. But what I feel is that if we choose a needy area, along with the district or whatever, it works out better. And I think when we gave that area to the students, the next batch, it was easy because no more work to be done in that area. No more pioneering work. The community knew us, we knew them. And one more thing I want to add, before giving the area to the second batch, I did a community survey asking how many of them wanted students in the next round. I think 5 houses said they didn't want because they were out or they felt they didn't need this. They felt it as an intrusion. So those houses we excluded. All those houses which said they need the students again, we gave them. We handed it over. That's in short. Thank you.
Thank you, Dr. Sairav.
Thank you, ma'am. Let's conclude this session. First of all, thank you all the expert panelists for their time and insightful thoughts on the vast topic of family adoption program. Today's session highlighted the importance of the key pillars of FAP, the faculty mentorship, along with the student engagement and the community participation. This will increase the sustainability of FAP in all the colleges across India. Let's FAP is a bridge between class and community. Let's all us together strengthen that so students, community, and the institutes benefit at large. Thank you. Thank you so much.
Thank you. Thank you for
Over
the
to Dr.
opportunity.
Vijay Karthikeyan, sir.
Thank you.
Thank you. So I would like to, on behalf of IAME, I would like to express our heartfelt gratitude to all the expert panelists for accepting our invitation and sharing their insights and their expertise in today's panel discussion. I would like to express my heartfelt thanks to the moderator, Dr. Mohit, as well as the office bearers of IAME, and not but not least the active participation from the participants, and also they have posted many queries in the chat box which were answered by the panelists, and I hope that all of us would have learned some new insights from this panel discussion, and we are moving towards sustaining this FAP, and we are also learning in the over the years from both the students as well as the community stakeholders. And we hope that it will be a very successful program from NMC. So we will meet you all soon in some other activity from IAME. Thank you all for joining for today's session. Thank you, sir.
Thank you.
Thank you, madam.
Thank you, sir. Thank you.
Thank you, everyone.
Thank you.